So, may I have your attention, esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event hosted by the National Neonatology Forum, Gujarat State Chapter. And the focus of today's session is panel discussion on immediate management of common birth defects. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Iyer, sir, the Honorable Secretary of NNF Gujarat Chapter, to start the event today with his enlightening words and for the further coordination. So the dais is all yours, sir. Please proceed.
Thank you, Ritu. So today, this month is the birth defect awareness month, as we are all aware about it. So we have planned a panel discussion, and in the panel discussion, we have the esteemed faculties, our teachers of teachers, Dr. Uma ma'am, Dr. Sheila ma'am, Dr. Nehal ma'am, and our moderator would be Dr. Monish sir. So first, I will request Shwetal ma'am to say a few words, and then we'll proceed.
Not wasting much time. Good afternoon, dear all. I'm extremely thankful to esteemed panelists for accepting the invitation. This was the last moment decision to celebrate the month as a birth defect month. And I'm really thankful for accepting the invitation. Thank you so much. Over to you, Monish bhai.
Thank you, madam. Welcome to all the esteemed faculties. Today we have in the panel discussion, we have the three faculties. Dr. Nehal madam, she is a professor and head of the Department of Pediatric, GMARIS Medical College, Sola. She is an executive board member of Central IIP 2023-24. She was an executive member AOP Gujarat in 2022. She was a founder president of Women's Wing AOP Gujarat 2021-22. EB member Academy of Pediatric Ahmedabad 2021. And she has also organized many conferences as an organizing secretary based on Pedicon 2023, joint organizing secretary based on Neocon and Push Neocon 2022. She is a member of National AAFI committee member, and she is a national coordinator of B4U and Beyond the Modules. Her special interest in pediatric intensive care, neonatology, lactation management, and pediatric hematology, adolescence care.
Thank you, Monish bhai.
Thank you. Welcome, madam. Our second speaker is teachers of teachers, Dr. Uma madam. She is a MD Pediatrics and DPED. She is a professor and head of the Department of Pediatrics from Parul Institute of Medical Science and Research at Baroda. She was an ex-professor, Department of Pediatrics at Baroda Medical College, and also the superintendent of Baroda Medical College and coordinator of medical education units, Baroda in 2011 to 2017, and advanced courses in medical education 2015. She was a president of National Neonatology Forum, NNF Gujarat State. Her area of interest is governing. It's a past president of IIP Baroda. Her publications, she has Oration of Gujarat State NNF, Publication International 12, and National 17 and State 5. Welcome, madam. Our third speaker is Dr. Sheila Iyer, madam. She has done her MBBS and MD from MS University and fellow in neonatology from Australia. She was a former professor and head of the Department of SSG Hospital, Medical College, Baroda. He is recognized undergraduate and postgraduate teacher at MS University, Baroda for pediatric and MBBS and MD at MS University and various other universities. Her field of specializes neonatology, nutrition and growth and development, director of pediatric hemophilia clinic, and the Gujarat State NNF Oration 2022. And she was organizing experience as secretary NNF Gujarat State Chapter 2003-4. And she was a president-elect Gujarat State NNF 2011 and 12, and president Gujarat State Chapter NNF 2013 and 14. Welcome, madam. So today we have the 4 case presentation. We'll start with the Dr. Nehalman and Kunal bhai case. Share karjo.
एक minute.
Oh.
મારી સ્ક્રીન વિઝિબલ છે ને?
Yeah.
Yes.
ઓકે સર.
first case to the Dr. Nehal madam. That's a single full term 40 weeks, 34 3.4 kg birth weight, male child, vaginal normal delivery, the clear lical, baby delivered by normal vaginal delivery. On examination, baby had a cleft palate. Now the question is, what is the initial management and how to approach this child?
So any child, when we receive it at birth, we always look once for the neonatal resuscitation required or not. So baby cried immediately or not. So as all the history is given and the baby cried immediately, now what we go for is the universal screening for any congenital birth defects. So after looking at the vitals, that the baby is now euthermic, has completed the any no major congenital malformations which can hamper the child with the life. After that, we can go for the other congenital birth defect screening, and one of them is very visible, that is the our cleft lip and cleft palate. So now this baby has the cleft palate. So our concerns will be how we will feed this baby. That is the first thing comes into our mind whenever we receive a baby with cleft lip and cleft palate. But with that, as there are many other associations of the cleft palate with the syndromic babies, we need to screen such babies for specially for the SpO2, that whether these babies are having any cyanotic congenital heart disease associated or not. And if it is not, whether baby is not in shock, is the baby in distress because of any other thing? If these things are not there, SpO2 is normal, we can proceed for the further management of these babies, especially for the feeding and as the time goes beyond that. So how do we feed this baby? Like for cleft lip and cleft palate, we have variety of the patients. Some do have only cleft lip, some have cleft lip and cleft palate both, some do have only cleft palate. So what is the etiology or what are the predisposing factors if we think about my maternal smoking history, maternal history of any other habits, less folic acid ingestion, or maternal hypertension, diabetes? So many factors are there which predisposes the child to have a cleft lip and cleft palate. If there is only cleft lip, we are not much worried about, because palate is there which can give a proper seal to the baby. But if there is cleft lip and cleft palate both, yes, we are very much worried about. If we look about the association, then generally the cleft lip alone, it is only 15%. And other things, 45% to 40 to 45%, both the cleft palate and cleft lip cleft palate combination that shares usually. So generally what we get is cleft palate, which is more difficult for the feeding. Now for these babies, always see, there are multiple things we have in mind, that we send this patient to the obturator for the obturator, or till now how do we feed, either by the RT feeding? Yes, RT feeding is always an option, it's not a problem. But if the baby is full term, can baby suck on the mother's breast? We can always try this. This is aglo video lone. This is Haberman feeder, but I would like to show that baby which was sucking at the breast in a vertical position. Because what we want to do is, we want to have a good suck and good seal at the breast. So baby can definitely achieve this, and with the gravity, it is directly going down. So no worries at all of the aspiration. When the baby grows old, they can even fed with the horizontal position anti-aglovidiogen. Horizontal position, but somewhat upright, when that same baby grows more. Okay, if we are so much concerned about not having such a good seal, even with the cleft lip and cleft palate, we can do have a feeders available. That is our Haberman's feeder. This feeder is having an elongated tip, so that it goes directly up to the esophagus, covering that cleft palate part, and the baby can then definitely suck properly. So there is, yes, this is how the baby feeds from the Haberman's feeder. So that cleft is covered and it is going inside and the baby recovers very well. Another showing baby is comfortably feeding with the but again it is a bottle. This is also a bottle. So we try not to recommend bottle if possible till, or we can do it till we have an obturator in the place. The obturator which is done by the dentist, it generally requires a baby of around 15 to 25 days old. So once they take a measurements of the palate, forms the obturator for the baby, this baby the mother is placing the obturator. Now this obturator then seals off that cleft. Yes, very nicely. Another mother was placing that obturator. Yes. So see, the baby is having RT feeding, but now mother is trying to go for the obturator. And with this obturator, the mother can, if possible, she can feed at the breast, or this is how the obturator is inserted to the baby, and then it is fitted over the ears. And then with this, when upper palate is already sealed, they can go for the paladi feeding, or they can go for the breastfeeding if the baby is comfortable. So these are the options of management, feeding management, especially for this child. Now, what are the other associations we look for? So as we told that there are multiple congenital heart disease associated, we also need to look for the many syndromes associated with it. So many of you people know that there is Vandenberg-Butte syndrome, there is DiGeorge syndrome, there are ectodermal dysplasias, many others associated. Even not syndrome, then single genomic defects are also there, which is associated with this. After you ruled out everything, what are the treatment options for these babies? So the treatment is finally the repair of the cleft lip and cleft palate surgically. The cleft lip, they generally repair by 3rd or 4th month of the life. The cleft palate, that requires around 8 to 9 months old baby, and 10 gram of HB plus at least 5 kg of weight for cleft lip repair, and 5 to 10 kg between in cleft palate repair. So this is generally required for the earliest closure. Now, with this, there will be some other aspects we need to deal with. Is the babies who are having this, they do have a psychological problem afterwards because of the looks which are affected. There may be a revision surgeries which are needed for the lip because the baby is growing and there will be a scar formation. There are other things like phonation. So because this is an artificial thing, there are some problems in the speech development. Initially, when it is not repaired, the phones which requires the palatal closures, they will be a little altered in this babies. Plus, there is recurrent ear infection that can affect their hearing. These babies may have syndromic association that can also affect their hearing. So these all the things, and the multifactorial approach, especially the dentist. The dentist has a very main pivotal role here, because the dentitions are affected also here. The feeding part is also managed by them. And later on, the oral surgeon, the maxillofacial surgeon needs to chip in this. Then the speech therapist will chip in. So there is multifactorial association and we need to work as a team in these children. So that's how we go for the cleft lip and cleft palate.
Thank you, madam. It was a very nicely discussed, and what you point out is very important. That first and foremost is that we have to see for the universal and any other defects, association defect, because these are all are the generally syndromic babies, and we have to only cleft palate and cleft. We have to look for the congenital heart as well as all the associated effects. And first and foremost, our part is the feeding difficulties. That with the apparatus, we can come out with the feeding difficulties, and after that, it's a multifactorial approach. We have to put together and to give a better outcome of this baby. Thank you.
Thank you.
I could just add.
Yes, ma'am.
Achha, very nice presentation, and I know we have also now been following with this palatal shield. It has made the life much better. I would just like to add on follow-up. We need to, because we usually keep thinking that it is nutritional cause of growth failure. Due to midline cleft palate, one has to keep in mind pituitary causes for growth failure also, because they could be associated with pituitary causes. So in case you are giving adequate nutrition, still your linear growth is not good, probably a good case to be investigated for
Growth
GH.
hormone deficiency. Yes, yes.
Yes, ma'am. Thank you, madam. Yeah. We'll move on our second case to the Uma madam. That's a single full-term 40 weeks gestation, 2.9 kg female child by the LSCS. For the previous one LSCS, it was a clear LICA and there was a polyhydramnios. Due to repeated episodes of vomiting after the baby breastfeeded, chest X-ray was done and that shows the pulling of the intragastric tube. On day 18th day of the baby referred to you, madam. How we will approach to the baby?
Yes. Am I audible?
Yes, madam.
Yes, yes.
Yeah. So this baby, who is a good weight, 2.9 kg, 40 weeker female child, died immediately after birth, is actually a surgeon's delight that if it's a tracheoesophageal fistula, which has been referred at 18th hour, and if the weight is good, they are happy whenever they have to operate. But before that, when such a child comes, the child was fed, as you said, otherwise the vitals are okay, temperature a little low, but otherwise most of the things are okay, except respiratory rate is already 60. So what do we know? For if there are residents here, any child who vomits once or twice soon after the first feed, one has to, the antennas have to go up. And if we have not passed a tube earlier, this could have been a normal delivered child. And if we have not passed a tube, we should pass in a tube and definitely have to look for a tracheoesophageal fistula. Sometimes it is okay and it's not a fistula and maybe it's just an amniotic fluid gastritis, then we can get away, but one should always keep this in mind. So now this is a child where it's already coiling. So we know that there is an upper end esophageal atresia, that much is certain. Now, immediately once the child comes, we don't really bother about what are the types of fistula at that point of time. We take and immediately take him to the NICU and stabilize him. We all know the TABC, etc., the temperature, the airway, to whatever extent we have to decide, because just on oxygen, free flow oxygen, maybe if the child is maintaining oxygenation, fine, but it says IPPR. So if the child requires to be ventilated, one has to be a little careful and ventilate the child. But if the child comes out with only free flow oxygen, if this child has been caught much before lot of aspirations have been done, then not that each of these children will require ventilation, only because the child has already aspirated. And how do they aspirate? That depends upon the types of the tracheoesophageal fistulas. There are two ends of the esophagus. We are not talking about tracheal agenesis here. Sometimes we do see a tracheal agenesis also, which is an even more complicated. But here we are primarily talking about an esophageal atresia. So the upper end is blind and therefore there is coiling. And it could be blind or it could be connected to the airway. So if it is blind, the aspiration is more because of the blind thing gets full and then the child aspirates after vomiting. If the upper end is already connecting with the airway, then directly what you're feeding is going to go inside. So aspiration will be in a very much bigger way. As far as the lower end is concerned, again, the two options are there. Either it is blind. If the lower end is blind and the upper end is blind, then of course, when we take an X-ray, we will see that there is no air at all in the abdomen. And we need to just notice that. And if the lower end is connected to the airway, which is the commonest variety, upper end blind and lower end connected to the airway, then of course you will also see a air in the abdomen. Though there will be coiling, but there will be also air present inside the abdomen because the lower end is connected. So this is just to notice as of now. And so the present treatment and presentation will depend upon how bad the aspiration is, whether it only requires free flow oxygen or requires ventilation. And earlier, such surgeries used to be done in an emergency. My husband, being a pediatric surgeon, Once upon a time, they used to operate these children even in emergencies. But nowadays, most of the pediatric surgeries are done as planned cases because there is actually no emergency in this child. The emergency is no further aspiration to occur. That is what it is, and manage the vitals, the TABC. So TABC, of course, we can manage even with or without ventilation, but no further aspirations to happen is what we need to see. So we have to continuously keep on aspirating, put in a tube, even if it's coiling, and keep aspirating so that any secretions there are taken away. Of course, if the lower end is communicating with the airway, then there could be aspirations by the stomach contents also. So that is one thing. But if we can wait for a few hours and there is it is operated in an non-emergency hour, the results are better. But if one is not able to, then one can go ahead with an emergency surgery. And the surgery will depend upon the variety, because if the space between the two ends is not much, they can connect it and a single stage surgery can be done. But if there is a long atretic segment in between, then of course there will be a long way. The upper end is exteriorized in the neck, and the lower end, and then a gastrostomy tube is put in. So once the child grows older, and then some anastomotic intestine or something has to be brought up and then operated later. But we are not worried about that. We are talking about presently. Now, after we have just stabilized even before surgery, but any congenital anomalies, we have to look for other congenital anomalies, because this could be again a part of the vectoral. So before surgery, if possible, a cardiac clearing should be done. So the anesthetist knows what the person is looking for as far as the cardiac is concerned, and then look for the other GI anomalies and part of the vectoral. So that is how we'll go about this child.
Thank you, madam. So in this case, like what exactly we want is once it is, we have to stabilize the child. We have to prevent further aspiration. So there will be any complication further. And on surgical side, once we stabilize, we have to look for any other congenital anomalies. That is the most important part of the stabilizing the baby. And after like what is the variety, then depending on that, the surgeon will decide the surgeries. Thank you, madam. The second case, again with the Uma madam. This is a single full term, 37 weeks, 2.4 kg male child. It was a clear LICA, no maternal morbidity, single umbilical artery. The baby was breastfed after delivery, but developed abdominal distension and repeated episodes of vomiting. Baby did not pass stool till 26 hours, and hence referred to your unit for imperforated anus.
Yes. So these are babies we are seeing, but hopefully much less than what once upon a time we used to see, but still we do see. And imperforate anus is the common terminology which we call, because we don't see the anal opening. But first of all, okay, the child has already been diagnosed and sent to us. First thing which we are going to do is stabilize. And temperature is again low, so we'll take care of the temperature, airway, breathing, SpO2, everything is otherwise stable. So this child will be taken into an ICU, but the stability is good, except that the child has vomited many times and may have aspirated, but fortunately the respiratory rate is normal. Now, we all know that all the babies who are born, whether by procedure or by normal delivery, the first examination includes top to bottom looking for congenital anomalies, and one of them is all the orifices. So normally, every child who is born, we don't put in a tube looking for a esophageal atresia or opening of the anus, but some of the practitioners who regularly go to a gynecologist, sometimes just for surety, they might put in a tube upper, as well as pull out and take the same tube and put it just for a short distance inside the anus. And if it comes stool stained, then they are very sure that there is, the opening is normal. No, I'm not saying that has to be done in everybody. Then when we examine, before this child would have come, or even after the child comes, when we examine the anus, there are one or two possibilities. One is maybe the anal opening is not there at all. So that's one. Second is the anal opening may be visible, but if the meconium has not been passed for so long and there is abdominal distension, it's good idea to pass in a little tube and see whether it comes meconium stain. If not, then there is some atresia just above that. Either we call it an imperforate annus, we call it a rectal atresia, and the best terminology now used by pediatric surgeons is ARM, that is anorectal malformation, because we really don't know exactly where the block is. So anorectal malformation is the best terminology. And the varieties in this is going to be sometimes later on before surgery in this child also we will take an X-ray. Some people like to take an invertogram. Most pediatric surgical units now take what is known as the cross-prone lateral film. That is, the baby is put prone on the table and the shoot is taken from the side. The lateral side of the baby is taken. So cross-prone or lateral on the table, that is the best film to be taken. And in that, you can make out whether it's a high variety or a low variety anomaly. That is one. Secondly, the chances are very high, they say, though we don't tend seeing so much of fistulas in males, but sometimes these children come with, being diagnosed as an, anus being placed very much anteriorly. The anal opening is not there in the anal position, but a little ahead, and very little meconium is coming out. Usually, this is not the anus actually, but this is a fistula into the perineum. So there may be a fistula into the perineum. Such a child may be a little delayed in diagnosis because the distension may not come in or vomiting may not come in. And sometimes surgeons would like to just open it a little bit so that the distension is gone. They get some more time, a few hours more time to operate for a colostomy. So there could be a perineal fistula. And in females, sometimes what happens is there is a recto-vesical fistula. I mean, vestibular fistula. So the child may be passing stool through the vagina or in the ureter. So one of them, then these are also diagnosed pretty late. So these are some of the varieties we look for. And whenever there is a high anal, imperforation, that is anorectal malformation with a high variety, of course, such a child requires a colostomy. Again, not to decrease the importance, this child again could have a lot of anomalies associated. We have to look for the tracheoesophageal fistula. We have to look for, again, cardiac and all the vectorals. Usually the anesthetist insists that at least a cardiac clearing should be done before surgery, so they know what they are, what to expect during anesthesia. And the best colostomy done usually is a sigmoid colostomy and not a transverse colostomy, which used to be done earlier. And the pediatric surgeons tend doing a sigmoid colostomy. And then this child will have later on a pull-through surgery a few months later, and then closure of the the colostomy. Some centers have started doing a single stage repair of all this. Most centers still do not do. So this child, again, it's a 2.4 kg, 37 weeker. Okay, delight for a pediatric surgeon, because if it was a 40 weeker and a 3.5 kg, much better. But still, a term 2.54 kg colostomy surgery is not a problem. And so that's how this child has to be handled.
Thank you, madam. Again, like it's the same, we have to look for the other congenital anomalies. That's always and if any child with any routinely, we have to look for the universal congenital anomalies, and we have to look for all the openings. And now like what we used to take an inventogram, now it's a cross-prone lateral film has to be taken, and we have to mark for the high variety or the low variety. And if it is a high variety, we can go for a colostomy or the single stage pull-through surgery, or low variety, they will look directly to surgery. Thank you, madam.
Thank you.
We will move to the fourth case. That is a single full-term 40 weeks, 40 weeks gestation, 2.7 kg, female child, normal vaginal delivery. It was a clear lichen and no maternal morbidity. ANC scan suggestive of the neural tube defect. Meningomyelocele, ruptured meningomyelocele with hydrocephalus. Baby was delivered at CSC Palage and referred to you at the third hour of life with for the ruptured meningomyelocele.
Thank you, Monica. Yeah. Is my slide visible?
No, ma'am.
No, madam.
Not
One
yet?
No.
No? Because it's come on. Okay. I took share screen. Now it is.
No,
No.
ma'am.
Ma'am,
No.
your screen is not shared yet.
Yes,
Now?
ma'am.
Yeah, now it is started.
Now it's
Yes.
started.
Yeah,
Yes, yes.
yeah.
Slides are
Visible.
Okay. Good afternoon, everybody. Now,
Good
coming
afternoon.
to probably a scenario which is probably very, very difficult to deal with. One of the commonest CNS congenital malformation, and amongst the congenital malformation, next to CHD in its.
Ma'am, please make it full screen.
Yeah, just a minute. Now?
Yes,
Yeah.
Yeah. Okay. So coming to neural tube defects, mainly this case that we are going to discuss is a myelomeningocele, which has ruptured and there is already a hydrocephalus. Scenario where parents end up bringing in emergency hours because it is a nightmare to parents to see such a child. Again, they expect some miracles to happen. Unfortunately, though this was antenatal scan had shown, we have not yet reached a scenario where a proper antenatal counseling of parents would have been done. Usually, and at present, we are not even in a situation where even an option of fetal surgery, which is again very, very restricted in developed countries also, but even delivering at a place where something could be done instead of that delivers at periphery and then comes. So many other added morbidities could be there. One of the first question probably one would ask, there was hydrocephalus, there was a meningomyelocele. Should this child be delivered vaginally or a C-section? Because this is a big debate. Most of the time in our conditions, one would think that if can be delivered because the prognosis of such a baby is not very good, why give a scar to mother? Usually that is the view taken. While definitely a breech delivery would require to be delivered by C-section as per the most of the gynec society recommendation. Okay. So for infants with a prenatal diagnosis of myelomeningocele who do not undergo any antenatal intervention, delivery should occur at a center with a level 3 neonatal intensive care. If at all we end to plan to give this child the best possible intervention and the long-term outcome, which we would discuss in next 5 to 10 minutes. But definitely antenatal counseling of parents, delivering at a place where, because this requires multiple inputs and it is not a simple, as talked by my other colleagues, even most of the other congenital malformation, you need to rule out other malformations together and it doesn't become a single solo center's response. I mean, outcome definitely improves when they are at a center where their teamwork is available. One other important thing which is there, if you are dealing with a delivery and handling of a meningomyelocele, you need to use latex-free gloves. This is something which has been reported that latex allergy in this infants later is quite well reported. It can even cause anaphylaxis. To tell you the truth, when I started reviewing, I came across this, that latex was so much important to these babies. Even I was not. So during delivery and later on also when you are handling, the gloves should be latex free because they are at risk of developing life-threatening latex allergy. This has been a documented data, and American Society recommends in their delivery this itself that you need to use latex free. Term delivery is preferable, but increasing ventriculomegaly or a macrocephaly on ultrasound must necessitate a preterm delivery, but preferably after 34 weeks and with a coverage of steroids. Because already we have a issue which needs a lot of intervention, risk of sepsis. We would not like to have problems associated with prematurity. And fetuses presenting in the breech position are typically to be delivered by C-section. For vertex, yes, there can be a debate whether you would like to. but one which has a large meningocele which could get ruptured during delivery, or the head is large, one may require to deliver them by C-section. But as I told you, we are many times taking this opinion that why give a scar to mother. These are other anomalies which, because I'm not going to cover how at what stage what malformation occurs in the embryological development, but very common to have Arnold-Chiari type 2 malformation, hydrocephalus in more than 80 to 90%, syringomyelia, I hope you're able to see the percentage which I have on the side put it,
Yes,
because
yes.
brainstem malformations. If you look at most of those malformations, like are very commonly associated with, well, probably least is the polymicrogyria. So it's not just that there is a meningomyelocele. You, for a long-term outcome, all this is going to make an impact as far as. So proper counseling and really talking to parents and family is very important. And in my 35 years, I've always seen that probably no surgeon is really, really very enthusiastic in taking them for surgery early as well as for management, because in view of the long-term morbidity and this, there was a time even in Western country that do not intervene. They almost had 97% mortality in infancy. After they have gone intensive in the management, they have now better survival. But then there are a lot of challenges, even with survival, because for every other complication you need to, and in the first decade also, a lot of complications and a death can occur. Okay, so sterile non-latex gloves should be used to minimize the risk of latex sensitization when you do the first examination. The infant should be placed in a prone or a lateral position to avoid prolonged pressure on the lesion. So these babies need to be kept prone or lateral throughout, because otherwise you would cause this pressure. Now you look for what is the site and the level of the lesion, presence of CSF leak is there or not, motor and sensory level. In your neurological examination, you would like to have to do it. Associated hydrocephalus clinically visible or on ultrasound, presence of associated symptomatic hindbrain herniation and other malformations, which you would get it on your MRI, because the neurosurgeon first is going to definitely ask you for an MRI when many cases even fetal MRI can be done, and presence of orthopedic deformities, because they are very, very commonly associated as a malformation associate. So basically, we all know that it's a failed closure of dorsal neural tube. Lesion, as I showed in my first picture, red, raw neural plate structure devoid of dura and skin covering. Some of those lipomeningocele would have intact skin covering also. And it has a lot of fragile vessels when CSF can be very well seen because they are brilliantly transilluminant on transillumination, and many times, as in our case, could have even ruptured. While a meningocele contradiction does not have a neural tissue in the sac and has a nearly complete skin covering, which has a much better prognosis, but definitely requires other associated investigation to be complete. And open neural tube defect should be immediately covered with a saline moistured sponge or a dressing which is not a gauze. Because what happens, gauze, those fibers will stick to this issue. So you're not supposed to use, but use a sponge or a dressing which does not have any material which would stick onto the meningomyelocele. Okay. And if it is not ruptured, avoid rupture of the sac and drying of the exposed neural play cord by using a saline moisture. Avoid using a wet gauze. As I said, the fibers can stick to the exposed tissue, and usually they need to be maintained in lateral and recumbent position, as I told you. We would have to take naturally intravenous line. Initially, we may not fully do a full assessment before we decide that how the child is going to fit. So our TABC needs to be taken care of. This is a case where probably if you look at any recommendation, they are starting prophylactic antibiotics if at least it's ruptured. Kind of because they are vulnerable to develop meningitis because of the leaking CSF. Okay. In neurological examination, one would look at from the level of meningocele, spontaneous activity in the limbs lower down, extent of muscle weakness and paralysis, response to sensation, deep tendon reflexes, and anocutaneous reflex and anal wink. Because most of the time they are associated with a patulous anus. Level of spinal cord and other things, evidence of brainstem compression, newborn should also be evaluated for associated other malformations. So I think which my other colleagues have also talked about, but kyphosis and bony spinal cord deformities and gastrointestinal tract, kidney, hydronephrosis, absent kidney, all could be. Developmental dysplasia of the hip is very commonly associated with this neural tube defect. So multiple again defects could be a possibility. Again, see here it comes to a team of geneticist, neonatologist, pediatric neurosurgeon, pediatric orthopedic surgeon. Everybody should be evaluating depending on the malformation that the child has. And as even in this history, because folate deficiency was commonly thought of, and that has decreased the neural tube defects. We are not seeing anencephaly now due to early ultrasound. Probably I also saw during my residency, Uma Ben would have seen during her residency that we used to see anencephaly getting delivered. Now at least they are terminated early if found in the antenatal. And this mother was on anti-epileptics like carbamazepine or sodium valproate, very two important drugs which are associated with neural tube defects. One would go for an early ultrasound of the brain as well as kidney, echo for heart. So multiple other malformations to be ruled out so that one knows. MRI brain and spinal cord to know the other associated, the list that I had put up. Urological examination for ultrasonography of kidney and to know the kidney anomaly, orthopedic evaluation, and sensory and other. Probably I would just go through quickly. Now, how timing of the surgery. I think over last 35 years with various neurosurgeons and plastic surgeons, even at SSG, as I told you, still we do not have a very good teamwork always. There is, again, timing has been varying with many surgeons, but what the current guidelines and recommendations say that earliest, at least latest by 72 hours. One has to get them operated, because when you did that, at least in 3 to 7 days, the image showed a little difference in survival, ventriculitis or worsening paralysis, but one should do it at least by in first week between 3 to 7 days. Surgeons could plan and deliberate what all can be done together, shunting to be done together so that most of them have a hydrocephalus or develop hydrocephalus on follow-up as soon as you close. And so with a single anesthetic exposure, probably, and already there is a ventriculomegaly, then the shunt placement can be done in them. Okay. So any major procedure in neonate, what it involves, like other surgery for TOF or surgery for anorectal malformation, this requires pre-anesthetic checkup, proper management during anesthesia for hypothermia, hypovolemia, and all major vital functions. They may require to be ventilated during that. So all that holds true for this also. I will not go into the details of the surgery, but definitely there is a very important component of what they have realized from their MRI and what they are going to do. And skin closure is also achieved by mobilizing the skin from the underlying paraspinal fascia. And it's closed in layers, and care is taken to avoid necrosis or ischemia of this flap. And many times we have seen that the flap gets necrosed, and skin closure should be protected with a sterile dressing, because all these babies are come for post-op care to us only. So we do need to know that what has been done and what is to be followed up. Okay. So for shunt placement, 20% of all patients would have significant hydrocephalus, which they would have. Another 60 to 70 develop it after myelomeningeal seal is closed. So the surgeon does take a call whether he wants to do it along with it or not. And placement of a shunt during the same operation for closure is entirely a reasonable thing, even if it's not very large ventriculomegaly. Because patients who manifest ventriculomegaly after birth undergo shunt placement and closure while under the same one single induction of anesthesia. Simultaneous shunt placement only decreases the future anesthetic risk, but decreases the chances of CSF leak, which would have occurred through the closure, sutural or the flap closure that it would occur, because the pressure increases and it could lead to a leak from there. Okay. Many times when post-op such children die, we feel that was not taken care of. But remember, signs and symptoms of problematic Arnold Chiari malformations in neonates may present with stridor with vocal cord paralysis. We keep attributing it to the anesthetic intubation and not taken care of. But that is, if he has that malformation, he can come with this. Central cause of apnea, aspiration, dysphagia, hypotonia, progressive brainstem dysfunction, myelopathy, hypotonia, and quadriparesis, nystagmus, strabismus, which are progressive, swallowing difficulties, and suck. So these are all could be primarily the neurological problems and which lead to post-op problems for us when we are managing them in NIC. Okay. Coming to outcome and prognosis. After doing all this, naturally parents had such a big expectation that this would be closed and my baby would be fine. We all have seen they end up staying in our NICU and postnatal ward for weeks together. They keep recurrently getting admitted also because the outcome and prognosis depends on the hydrocephalus. What is the intellect outcome? Depends on what are the other intracranial abnormalities associated with it. Ambulatory, will this my child walk? Will this my child would have bladder bowel control? These are the questions which parents come with us. And it all depends, as we know, what was the initial status, as well as maybe initially it wasn't bad, but during surgery, a lot of complication occur and you may develop these complications even post-op. Issues of continence, fecal incontinence, encopresis, orthopedic problems, employment and independent living status at a later, and the late complications like tethered cord and latex allergy have now been reported in many issues. Western countries, they go intensive in managing these babies. They have better outcome. They survive through up to adulthood also. And all these outcomes would depend on what were the associated CNS malformation. And the hydrocephalus, the shunt infection, shunt displacement, in meningitis, many other things add to overall long-term prognosis. So recognized causes of death in a case of meningomyelocele, which has ruptured, and we have done intensive treatment, still it could be shunt malfunction, seizures, infection, uncontrolled brainstem symptoms from Chiari type 2 malformation or hydrocephalus. But ACOG as well as American Society aggressive treatment of neonates having this kind of presentation in United States. Okay, I think with this, I have covered only the meningomyelocele part and not the other neural tube defects, because there is a list of other anomalies which can come under this. But the most common and the worst one which present to us are usually the ruptured meningomyelocele. So I restricted my presentation to that alone.
Thank you, madam. The important part in the neural tube defect is the good ANC screening and ANC ultrasound. We should pick up as early as possible so we can avoid the further complications. And if it is possible, we can, like it is a measure, we can termination of the pregnancy, or that is possible. That is the base part. Otherwise, it's a multidisciplinary approach and it's a complication. And the thing important is that if it is delivered, it should be delivered on a tertiary center where all the teams should be aware and they should be available. Thank you, madam.
Thank you.
Thank you all the panelists. It was a very nice discussion and it was a very informative talk by all the three panelists. Thank you very much. Over to Kunal Bhai.
Thank you all the three panelists. It was very informing and a crisp and precise presentation. Thank you, Monish sir, for moderating it excellently. So it was in the last few days only we decided to take this panel. So, but still, I think it was very well done. Shwetal ma'am, you want to say anything?
No, that's all. Thank you so much. Yes, in last 48 hours, we decided to come up with the panel discussion and selected this most common. Like I was feeling that maybe it may be too short session, but the way it has been elaborated in detail by all the esteemed panelists, excellent session. Thank you so much. We will be disturbing all three panelists again and again for neonatal Pathshala. So please accept our invitation and share your experiences. Vast experience all three of you have. Thank you so much. Thank you.
Thank you.
Thank you. Thanks, everybody.
Thank you so much,
Thank you.
Vital, and you are not disturbing at all.
Thank you so much. Thanks.
Over to you, Ritu.
Any questions from the student? If not, then it's okay.
The chat box, there are no questions, but
Yes.
There
Ma'am,
was
we
no
haven't
want to
received any
ask the
questions for
panel.
today.
Thank you, NNF State. Anytime for Gujarat State NNF in the middle of the night also, we'll say okay for a webinar.
Thank you so much, ma'am.
Thank you. Bye-bye.
Thank
Thank
you.
you.
all.
Thank
so
you.
much. Bye.
So, thank you, dear doctors, for sharing your valuable insights. I hope you had a seamless experience. So, once again, thank you very much for extending us the opportunity to host the session today, and looking forward to host you again very soon in another interactive session. So, till then, stay safe and healthy, and have a nice day. Goodbye to you all. So, with all your due permissions, then we are signing off for today. Goodbye, ma'am.
Goodbye.